Now we move to endometrial neoplasia. Our case is postmenopausal bleeding. 65-year-old woman complains of vaginal bleeding for 3 months. Her last menstrual period was at age 52, and since then has not had any bleeding. So for 13 years, no bleeding. Now she's had bleeding for 3 months. When you have a postmenopausal woman who is bleeding, you better think of endometrial carcinoma, even though most patients probably don't have endometrial carcinoma. That's the worst thing, and you need to rule it out. She has not taken any hormone replacement therapy. If she was on hormone replacement therapy, estrogen only and no progestin, that could cause hyperplasia and endometrial cancer. She has diabetes mellitus type 2 for 20 years. She has chronic hypertension, and she is 62 inches tall but weighs 200 pounds, so she has a high body mass index. Demographically, we know risk factors for endometrial cancer are diabetes, hypertension, obesity. So she has all 3 of those risk factors. Physical exam, including a pelvic exam, is normal. With no vulvar, vaginal, or cervical lesions, the uterus feels normal size for a postmenopausal woman. Does a normal uterine exam on a bimanual, does that rule out endometrial carcinoma? Not if it's limited to the endometrium. You cannot rule it out on physical exam. The only way you can rule it out is by doing a biopsy. You've got to do an endometrial biopsy. So postmenopausal bleeding is where you've had 12 months of amenorrhea with increasing gonadotropins and now bleeding. What we're going to be looking at is varying diagnoses for postmenopausal bleeding, atrophy, polyps, hyperplasia, and carcinoma. We will review this at the end of the section. The most common gynecologic cancer is endometrial cancer, followed by ovary, cervix, and vulva. The average age for endometrial cancer is 61. Do you think this is more likely to be a thin or an obese woman? More likely to be an obese woman. And what's the reason for that? Because the more peripheral adipose she has, the more conversion of adrenal androgens into estrone in the peripheral adipose. So obese women are more likely to have it. If we look at 100 women who have postmenopausal bleeding, only 15% of those will actually have endometrial carcinoma. We could have endometrial atrophy, estrogen therapy we talked about, polyps, hyperplasia, and miscellaneous. But we need to rule out endometrial carcinoma. The pathophysiology is unopposed estrogen. See, progestin stabilizes the endometrium. If we have excessive hyperstimulation of the endometrium without the stabilizing effect of progesterone, we're going to increase the likelihood of endometrial hyperplasia and therefore the likelihood of endometrial carcinoma. So any woman who has high levels of estrogen without progestin is at risk. Now the risk factors, we just talked about that. Obesity, hypertension, diabetes. I don't think hypertension has anything to do with it. I don't think high blood sugars has anything to do with it. It's just that hypertension and diabetes go along for the ride when you have an older woman who is obese. So these 3 are the demographic risk factors. Women who have never had any children, more likely, because they haven't had the long periods of progesterone which you have with pregnancy. Late menopause and polycystic ovarian syndrome. Women who are anovulatory because of polycystic ovarian syndrome do not ovulate. They don't have the corpus luteum, which produces progesterone, which protects. The diagnostic tests, we must do an endometrial biopsy. Now, if we have a localized area which is involved, you may not get it on the endometrial biopsy, but you can see it on hysteroscopy, so we'll talk about that. The other thing is we can look at the endometrium using a saline sonogram. Could there be an endometrial polyp which is bleeding? We already looked at endometrial biopsy previously and how we do that. We put this cannula into the uterus, we create a suction, and then we rotate it around and hopefully aspirate endometrial tissue into the pipette, which we then withdraw. If you have a leiomyoma which is bleeding, you can resect that with a hysteroscope. You can look and see if there are lesions, and here we have a large submucosal leiomyoma. Notice how clean and sharp the edges are. This is benign appearing. Here we have endometrial atrophy. See how pale the endometrium is? And here we have areas of bleeding. These are the corneal areas where the tubes are going out. This looks at the endometrial stripe on ultrasound. Can you see how narrow this endometrial stripe is? It's very thin. It would be unlikely that this woman has endometrial hyperplasia or cancer. Look at how thick this endometrial stripe is here. This would be far more worrisome. Now, we can also do a saline infusion sonogram, where we put a catheter inside the endometrial cavity. We inject 5 to 10 cc's of saline. It pushes apart the walls of the uterus, and now with an endovaginal ultrasound, we can see whether or not there's any lesions. Now, this is a normal endometrial cavity. You can see there are no lesions in here. We can actually measure the thickness of the endometrium here and here. Now, the next picture you can tell is much different than this. Here you can see there's clearly something which is distorting the uterine cavity here and here. Now, this is a diagnostic, I should say it is diagnostic, but it's not therapeutic. You can't take these out, you can only look at them. So these will have to be resected with a hysteroscope. But if the cavity was normal, it would be helpful. Now here's a patient, and you can see the saline has outlined this polyp. You would never see it otherwise, but the saline makes it helpful to see. And here again. Okay, we move into endometrial cancer staging. This is to see how far it has progressed in terms of metastasis. And remember, all gynecologic cancers except cervical are surgically staged. So endometrial cancer is surgically staged. The most common stage, as you can see, is stage 1, limited to the uterus. Stage 2 is extension to the cervix. Stage 3, adjacent to the uterus. And stage 4 is distant metastasis. But the most common stage is stage 1. When we look at all of the substages, you can see there is 1A, 1B, 1C, 2A, 2B, 2A, 3A, 3B, 3C, and so on. What of these do you need to know? The most common stage is stage 1. So let's look at this one, because this is going to be the one most commonly seen. If you'll notice, stage 1 is spread limited to the uterus, and stage 1A is limited to the endometrium. It has not invaded into the myometrium at all. If you're going to have endometrial cancer, better to have stage 1A. 1B, it has invaded into the myometrium, but less than 50%. 1C, it has gone more than 50% into the myometrium. You can appreciate that the more the invasion, the higher the likelihood of metastasis to the lymph nodes. So the best prognosis would be stage 1A, well-differentiated endometrial carcinoma. Survival is clearly a function of stage. 90% survival stage 1, 20% survival at stage 4, and then in between. The most common stage that we see is in stage 1, and the reason because there's postmenopausal bleeding. Here you can see the endometrial cancer is limited to the endometrium. There is no metastasis into the myometrium. Here we have a small leiomyoma. This is stage 1A. Here you can see it is spread into the myometrium more than halfway. This is stage 1B. C. This can result in a large uterus. When it is 1A, it may be just a regular-sized normal uterus. I would also point out that endometrial cancer, as it goes through the myometrium, can then invade through the fallopian tube, go to the ovary, and you can have ovarian cancer metastatic from the endometrium. In terms of management of endometrial cancer, TAH, total abdominal hysterectomy, bilateral salpingo-oophorectomy is a basic treatment for all stages of endometrial cancer. Now remember, for cervical cancer, the early stages can be treated with hysterectomy, varying degrees, a simple hysterectomy, a modified radical hysterectomy, or a radical hysterectomy. But once you get the more advanced stages, it is going to be radiation therapy. This is not true for endometrial cancer. All stages, 1, 2, 3, 4, the basic treatment is TAH-BSO. And it is abdominal hysterectomy because at the same time we can do staging and we can look at the lymph nodes and see if there's any enlargement of the lymph nodes. So based upon what we end up with, we may have no further treatment other than the TAH-BSO for stage 1A. And as we progress, we may have radiation therapy, we may have chemotherapy, which is also added. The likelihood of cure is very high in stage 1. The likelihood of cure in stage 4 is probably minimal, and we're looking at palliation at best. Okay, prevention. The pathophysiology of endometrial cancer is unopposed estrogen. Estrogen without the stabilizing effect of progesterone or progestin. So, in terms of prevention, anytime we have unopposed estrogen, we need to provide progestin. For postmenopausal women who are on estrogen therapy, if they have a uterus, they will need not only estrogen but also progestin. And the only benefit of the progestin is to prevent that endometrial hyperplasia and the stimulation. Progestins actually antagonize the favorable effects of estrogen on the blood lipids. Estrogen increases HDL and decreases LDL. Progestin does just the opposite. But we will take that risk because we want the benefit of preventing endometrial cancer. Okay, women in the reproductive age group also may have unopposed estrogen, and that is typically your polycystic ovarian syndrome. Now, these women have a tonically elevated level of estrogen, but because they're not ovulating, they don't have the progesterone from the corpus luteum, so they are at risk for endometrial hyperplasia and carcinoma. But they don't need estrogen, obviously. All they need is cyclic progestins. So any anovulatory woman, we want to prevent the hyperplasia and potential progression to endometrial cancer by giving progestins. All right, here we go. The natural history. Simple hyperplasia without atypia, if there is unopposed estrogen, can become complex hyperplasia without atypia, can become without or with unopposed estrogen, complex hyperplasia with atypia. This is a cancerous precursor. And over time, this can become endometrial carcinoma. So unopposed estrogen can take us from here with simple hyperplasia all the way down to endometrial carcinoma. Now the treatment, let's look at simple hyperplasia. This can be medical treatment. Progestin can stabilize the endometrium and prevent the progression. Complex hyperplasia, no atypia, the same thing. Medical treatment, progestin can do that quite well. When you have complex hyperplasia with atypia, this is a precursor to cancer. I would prefer to do a hysterectomy, either a total abdominal hysterectomy or total vaginal hysterectomy. If the patient is not a good surgical candidate, let's say she's got cardiac disease, she's got pulmonary disease, she's got vascular disease, then you may try progestin. But anytime there is endometrial cancer, that is always with total abdominal hysterectomy bilateral subpingual oophorectomy, because you've got to do a staging procedure, and you've got to do that surgically. One of the most common progestins used is medroxyprogesterone acetate. The trade name is Provera. However, you will hear me talking about MPA, medroxyprogesterone acetate. Now, you notice this word progestogen. This can be used in the same places as you can progestin. They're really synonyms, progestin or progestogen. I prefer progestin. All this means is that it's not progesterone, but it is a progesterone-like synthetic steroid. This figure looks at the relationship between endometrial cancer and oral contraceptive use. These are many studies that were done, and what it looks at is relative risk. A relative risk of 1 is about average. If we have a relative risk which is over 1, that is increased risk. If it is less than 1, it is a decreased risk. And you can see with one exception, all of these studies show a 50% decrease in endometrial cancer in women who have used oral contraceptives. And the reason is because oral contraceptives, by and large, are combination, estrogen plus progestin, and it is a progestin which stabilizes the endometrium. So that would be a good board question. Oral contraceptives reduce the risk of endometrial cancer by up to 50%. Now, this is an interesting figure. It looks at the endometrial cancer rates in the United States, which is the hatched line, and the solid line is Japan. Now, how can one account for this? This is a significantly increased risk. Do you think it's because women in Japan are not as obese as women in the United States? You know, when you look epidemiologically at the differences in cancer rates, while yes, there could be a genetic component, I think there's a dietary component which is significant. And I would say, could it be the tofu? Could it be the tofu? This is an interesting article. This is from China, where they looked at Chinese women having lower rates of endometrial cancer. And why is this? Soy, tofu, reduce the risk of endometrial cancer by 30 to 40%, especially in obese women. And there is very good evidence that diet is risk to breast cancer. The American Cancer Society says half of cancer deaths are preventable in the United States if Americans had a healthy lifestyle, stopped smoking, exercised more, ate healthier food, and get cancer screenings. So diet, I think, can make a major difference. This is from Time magazine a few years ago. Should you be a vegetarian? Millions of Americans are going meatless. What do you think of that? Good idea? This is the Adventist Health Study, which has been conducted for the last 30 to 40 years from Loma Linda University, where I teach in California. The Seventh-day Adventists basically have a healthy lifestyle and have been looking at, in a prospective manner, what is the outcome varying on their lifestyle differences. And what they found was vegetarian diet, add 2 years to your life. Regular exercise, add 2 years to your life. No smoking, add a couple of years. Normal weight from whatever reason, I mean, no particular diet is better than other by this study, add another 2 years. And then be a little nutty. Eat nuts. Another 2 years. 10 years added lifespan. This is Dr. Sabati, who is from Loma Linda, and he has done studies now looking at walnuts, at cashews, at almonds, at a variety of nuts. Now, they have high fat, but it's a good fat. Be a little nutty. Working long hours is harder on a woman's health. And this looks again at lifestyle. It says that working long hours has greater negative impact on women than men because it makes them more likely to smoke, drink coffee, eat unhealthy food. What more can I say? All right, good board question right here. What selective estrogen receptor modulator is associated with increased risk of endometrial cancer? And that is tamoxifen. Tamoxifen is a selective estrogen receptor modulator that has an estrogen antagonist effect on the breast, but has an estrogen agonist effect on the endometrium. And here you can see a large endometrial polyp which was induced by tamoxifen. So if you would remember, endometrial cancer needs to be watched for in women who are receiving tamoxifen, either because of breast cancer or because of attempt to prevent breast cancer. All right, let's summarize what we have just said. Patient comes in with postmenopausal bleeding. Obviously, you want to do a speculum exam, see if there's a vaginal lesion, if there's a cervical lesion. We'll assume that that has been ruled out. Now we have to look at upper tract, and we must get a tissue sample from the upper tract, which is in the uterus. We can do this using an endometrial biopsy. I showed you how you do this. An endometrial biopsy, however, only samples a very small amount of the surface of the endometrium, probably in the range of 2 to 5%. You could very well have lesions such as polyps, which you would never see, and that can be identified using hysteroscopy. So we take our tissue sample, either by endometrial biopsy or hysteroscopy, send it to the pathologist, and when it comes back, we'll decide what to do. If the finding is atrophy, how do you treat atrophy? With estrogen, but she has a uterus, so she's going to also have to have progestin. The body mass index of a patient with atrophy is probably low because she has less peripheral adipose, which converts androgens into estrogens. If you see a polyp, those are usually benign, and you can visualize that hysteroscopically, just take it out. Hysteroscopic resection. Hyperplasia. If you have hyperplasia, if it is simple without atypia, and this is important, if there's no atypia, then usually you can reverse it with progestin. Medroxyprogesterone acetate, then we'll repeat the biopsy in 3 to 6 months. If it is complex hyperplasia with atypia, and what the complex means is there is decreased stroma and more glandular tissue, and ugly-looking nucleoli, then we want to take the uterus out, total vaginal hysterectomy or total abdominal hysterectomy. If it is carcinoma, we've got to find out the stage and the grade. Endometrial cancer is staged surgically. We have to take out the uterus and see whether it is invaded into the myometrium, then also check the lymph nodes. You'd like to have stage 1, grade 1, well differentiated. In that case, only total abdominal hysterectomy, bilateral salpingo oophorectomy. If it is more than that, you may need to give progestins, you may need to give chemotherapy, or you may need to give radiation therapy. That is the end of endometrial neoplasia.